Have you ever wondered if every ear infection needs antibiotics? And if so, for how long? Today's episode, we're going to talk about the recent research guidelines and whether or not your child needs antibiotics or not for ear infections.
Welcome to the Beehive Doc Talks with Dr. Blair Rolnick. As a pediatrician and mother herself, Dr. Rolnick is here to answer your most pressing parenting questions and guide you through the tough spots.
Welcome back to Be Kind Pediatrics. For those of you who are new to the show, my name is Dr. Blair Rolnick. I'm a pediatrician and mom. So who needs antibiotics and who doesn't need antibiotics? So we can really break this down into 4 categories. If you're told as a parent that your child has an ear infection, these are the 4 types of children who should be started on antibiotics immediately. Those less than 6 months because they have not completed their vaccinations against H. flu and pneumococcal. Those who are between 6 and 23 months and have both ears infected. Those who are unvaccinated against pneumococcal and H. flu. And those who are greater than 23 months and have what we call severe disease. So severe disease means that the child either is coming in with a fever greater than 102.2 degrees Fahrenheit or 39 degrees centigrade, that their pain is moderate to severe, meaning really for me, you've given them Tylenol, Motrin, and they're still in a lot of pain, or that they have been having ear pain for more than 48 hours. So in those instances, those children over 23 months should also be started on immediate antibiotic therapy, and that is really to reduce the rate of complications. In those 4 settings, it is more suspicious for a bacteria that is going to potentially respond well to antibiotics. Children who do not need immediate antibiotic treatment. So those are children between 6 and 23 months with non-severe presentation and 1 ear infected. But those greater than 23 months who have a non-severe presentation, meaning they don't have a fever greater than 102.2 degrees Fahrenheit or 39 degrees centigrade, they do not have severe ear pain, and it has not been going on for more than 2 days. In those settings, what we recommend is something called SNAP therapy. So there's different ways that practices put this into play, but what we usually do here is we prescribe the antibiotics. So we tell parents, please go ahead and pick these up in case your child has a fever on a Saturday at 7 a.m. or after hours at night. You have them and you can go ahead and start them. And if you start them, please let us know. So that's a prescription we're giving them at the get-go, but saying please don't start it unless you see these signs or symptoms. Or some practices will say, if your child develops these signs and symptoms, please bring them back so we can check their ear. And if they still have an ear infection, we're going to go ahead and prescribe antibiotics. Regardless of whether antibiotics are prescribed or not, there is definitely a role for pain control. So Tylenol or Motrin, depending on your child's age, are very important to help reduce the pain and to keep them comfortable, especially if you're not going to use, regardless of whether you use antibiotics really, because your body will, in most cases, clear this infection if you're not using antibiotics alone at all, but it doesn't mean that the pain is going to go away. And there's really, the emerging evidence doesn't show any difference in pain going away faster if we use antibiotics. So the antibiotics don't seem to help with the resolution of pain at all. So we really need to talk to parents separately about treating that. So now let's talk a little bit about the choice of antibiotic. So the choice of antibiotic really, again, has to do with several factors. One, the child's immunization status. We talked a little bit about pneumococcal and H. flu B vaccines preventing ear infections. So in children who are not vaccinated against H. flu or pneumococcal, they are more at risk or at higher risk for having those bacteria. Those bacteria, particularly H. flu type B, are what we call beta-lactamase producing organisms. And so those children should be started actually on augmentin or amoxicillin clavulanic acid from the get-go. Children who have failed amoxicillin treatment, meaning they've gotten 48 to 72 hours of antibiotics and are either worsening or not improving. Children who have what we call otitis conjunctivitis syndrome, so they presenting with an ear infection plus conjunctivitis or pink eye, that makes H. flu a little bit more likely. And so there's some argument that those children might need to be started on amoxicillin acid from the get-go. And then children who present on presentation with spontaneous rupture of the tympanic membrane or eardrum rupture, those children also are more likely to have a beta-lactamase producing organism and should be started on Augmentin or switched from amoxicillinic acid. And the last group of children are children who have been on amoxicillin in the last 30 days for whatever reason. If they develop an ear infection despite that, again, they're more likely to have a beta-lactamase producing organism and they should be started on amoxicillinic acid from the get-go as well. So now I'm briefly just going to cover who needs ear tubes and who doesn't need ear tubes. So I get a lot of questions from parents like, at what point should I be considering ear tubes or thinking about ear tubes for my child? We do have pretty clear guidelines on that. So any child who's had 3 or more ear infections in the last 6 months, or more than 4 ear infections in the last 12 months, with one of those episodes occurring in the last 6 months, should be referred over to the ear, nose, and throat doctors for consideration for possible ear tube placement. So we talked a little bit about who needs antibiotics and who doesn't, and what antibiotics we treat with. Now let's talk about duration of antibiotics, because that's also actually changed. About 20 years ago, we were saying that every child should get 10 full days of antibiotic therapy for acute otitis media. Over the last 2 decades, we've really inched that down to try to minimize the exposure patients have to antibiotics because they, of course, have side effects. And so as of 2013, the AP guidelines really said, if you are less than 6 months, full 10 days of antibiotics. If you are between 2 and 5, actually you qualify for 7 days of antibiotics. And if you're greater than or 5 to 7 days of antibiotics, and most people are putting into practice if you're older than 6, really reducing that duration to 5 days of antibiotics. So those are the AP guidelines. There are some international guidelines in Europe that are recommending 5 to 7 days for all ages. But either way, we probably should be doing a full 10 days for everyone. And so really, the older your child gets, the shorter that antibiotic duration should be. And that's really, really important to reduce harm to patients. So now we've talked a ton about ear infections. We've talked about how to tell the difference between the different types of ear infections, who needs antibiotics and who doesn't, who can go for shorter durations, potentially of antibiotics, and who needs broader coverage with amoxicillin and clavulanic acids versus just amoxicillin. Now let's talk about how good are we at actually making this diagnosis and how good are we as pediatricians to adhering to the 2013 guidelines. So the 2013 guidelines did 2 things, really. They said, 1, we don't have to treat everybody with antibiotics right away, and 2, we can shorten the duration of antibiotics for children based on their age. So we're about 80% good at adhering to those guidelines. That really shows there's a lot of room for improvement, which is why I really wanted to do this video, because I think it's important for parents also to be empowered with this knowledge so that they can say, really, like, does my child need immediate therapy? If they need immediate therapy, how long, and what are the risks and benefits to that? So some of the reason that we have shortened the duration and said that not everybody needs treatment is based off of studies that showed that there was no improvement in pain, no reduction in those cases in complications, and that the ear infections go away on their own in those subsets of children that we talked about. In general, the rates of complications from ear infections are anywhere from 1 to 5%. So those complications include spontaneous rupture of the eardrum and hearing damage and spread to the mastoid bone back here called mastoiditis. Those are some of the complications they looked at in some of these studies. So parents can feel pretty confident, I think, that based off of this research, if they are not given an antibiotic right away, that they are not putting their child at any more risk and that there's actually maybe more harm for their child in starting that antibiotic if it's not going to make a difference in the outcome of their clinical course. How good are we at making the diagnosis of ear infections? So this is really challenging in pediatrics. Pediatricians are anywhere from 50 to 70% accurate in their diagnosis of acute ear infections. Specialists are closer to 70 to 75%. So those are the ear, nose, and throat doctors. But we're all still pretty low, I think, on our diagnostic accuracy. And there are certain tools that can really enhance our ability to make that diagnosis. In the past, we used things like tympanostomy and pneumatic tools to measure the vibration of the eardrum, and that only moderately improved our diagnostic capabilities. But in the last 5+ years, I would say, especially in the last year, there has been a lot of research looking at otoscopic videos, enhancing our diagnostic accuracy and the use of AI. So I think the use of AI is going to be particularly interesting in the last year. There's been several studies looking at AI models to help improve our diagnosis between acute otitis media or those middle ear infections and otitis media with infusion, those who will not need antibiotics or benefit from antibiotics. They're anywhere from 91 to 98% accurate. So they are very good. The AI models are very good at making this diagnosis. When they become commercially available, I think they'll really improve diagnostic accuracy for pediatricians and ENT doctors alike, all primary care doctors, I should say. And actually the use of otoscopy, so video-based instruments to look at the eardrum, just those alone without the use of AI also significantly improve our ability to make the diagnosis accurately. So I'm just going to show you one option that we're using here. All of our patients go home with this TytoCare device to take home. And we use them in the office as well. And that is because the video does significantly improve our diagnostic accuracy. And so this is a little device that has a attachment like this, and it goes into the ear and it actually takes a video of the ear. It allows us to pause that image, to scroll slowly through the image, and to really take our time and look at it and make sure that we are seeing signs of infection and not just a bulging eardrum. So I really like this. There are several different instruments out there that are available for video otoscopy that both parents and clinicians can get their hands on. So this is a really common topic in pediatrics, but I do think it goes to show that even though it's our bread and butter and things that we see every day, there's tons of information out there and we're always learning new things, especially this last year with all the research studies going on with the use of AI models and making this diagnosis. I hope that parents find this video interesting and informative. I hope pediatricians, you guys find it interesting and informative. If you guys have any additional knowledge or comments you'd like to make, of course, as always, please leave them below.
Thank you for watching the Beehive Doc Talks with Dr. Blair Rolnick. For more episodes and her practice, visit BeKindPediatrics.com and don't forget to subscribe for more parenting tips wherever you get your podcasts. This information is for educational purposes only. It is not medical advice. Always seek medical advice from a qualified physician.